What's up, everybody? I am so excited about today's webinar. Actually, I'm just excited about today's presenter. So whether you're watching this live or watching the recording, let me just tell y'all how special Dr. Jeff Williams is. He is probably, I'm going to say this, and Jeff, you're going to laugh. Okay, y'all know those Dos Equis commercials. He's the most interesting man alive. It's not him. It's Dr. Jeff. He really is. Y'all just have no idea the depth of talents and wide varieties of skills he has and all the different things he's involved in. If y'all follow me on social media, you know I was showing a lot of promotional videos for Dr. J's event a couple months ago. The voice behind that was the Dr. Jeff Williams.
That was me.
That's why he has this really fancy studio right behind him. Y'all, you just don't even know. He is an artiste and a doctor in brilliance. And you really do have like a really like huge passion and a heart to educate people about chronic pain. He is so involved in so many different things. We're in a lot of Facebook groups and social media groups together. We have a lot of mutual friends. He broke my heart when he decided to go up north in July. When I came to Texas for Chiro Expo, his pictures look like fun. He is one of the most fascinating people I have ever met in my entire life. And just really has not just a heart for this profession, but you have such a creative spirit too. And I just love that about you. I love when I meet people and I feel connected to them for the first time. And you were one of those people.
Oh, well, thank you. I felt the same way.
I paid him to say that. I'm just kidding.
That's not true.
But I am super excited to talk about this. You know, I think that my mama works with a lot of chronic pain patients. She's not a chiropractor, but she does work with a lot of people with chronic pain. And I think it's one of those topics of discussion that just really doesn't get talked about enough, and especially when it comes to chiropractic and chronic pain. So I'm super excited that you wanted to teach this today. So I'm going to turn it over to you.
Okay. So we're kind of learning how to use this system as we go. I'm going to hit the next button and I'm just going to take off. You ready? Okay. So just as an intro, I've been in practice for about a little over 25 years here in the Texas Panhandle. I'm originally from the Amarillo area, and that's where I live and practice today. I'm a former board member for the Texas Chiropractic Association. Currently, I am the department coordinator for scientific affairs for the Texas Chiropractic Association. So that's a pretty cool little spot to be, especially for a research nerd like me. And I've got a diplomat in the International Academy of Neuromusculoskeletal Medicine. That used to be the DACO program, which is the orthopedics, but they added so much neuro to the thing. I think they felt like they had to update the name, and I don't blame them. Also have a diplomat in forensics. I didn't even know what that was, but it's my mentor, Dr. James Lehman from University of Bridgeport, Connecticut. Kind of steered me down that path, and it helps me with medical legal work and expert witness type stuff. Then I'm also the host of the Chiropractic Forward podcast, where I discuss a lot about what's going on in my practice, what's happening, what I struggle with, what I've been successful with, and then we go over a couple of research papers every week that is relevant to our profession. And then last year, I released a book called The Remarkable Truth About Chiropractic, a unique journey into the research. It's categorized into neck pain, SI joint issues, the stroke issue, all of that stuff. It's categorized. And when you go to that category you're interested in, then you're going to find some of the most recent or relevant research papers for that particular topic. So it's a really good resource to keep up in research and to communicate that with your patients. Also, if you have any questions, be sure to email me at dr.williams@chiropractic4.com, creekstonecare@gmail.com. I'll get you there as well. So I've got about 82 slides in about 45 minutes. So let's just breeze through these. Let's start by saying more has been learned about pain in the last 10 to 20 years than they've ever known about it. So that's an easy way of saying that pain research has really, really gotten the focus in the past 10 years. And our knowledge level, our knowledge base has really risen as a result. So I'm going to read this quote for quote, word for word, because I think it's really important and it sets a basis for us here for the rest of the talk. Pain Science 2018 said, this is an article they had called Pain in a Nutshell. They say, quote, traditional pain models describing tissue pathology as a source of nociceptive input directly linked with pain expression are insufficient for assessing and treating musculoskeletal pain. Continuing on, they say other models reconceptualize pain and put forward concepts that are based on the premise that pain does not always provide a measure of the state of tissue pathology. We'll get into that more. Instead, pain is modulated by many factors, and the relationship between pain and tissue becomes less predictable the longer pain persists. So when we're talking about chronic pain, certainly 8 years, 10 years old, well, it's harder to really define and pin down, and definitely harder to get rid of. Also, they say unhelpful thoughts of patients and clinicians towards pain, including benefit that pain will not, including belief that pain will not get better and that movement will cause further tissue damage and worsening of the pain, are important issues to remain mindful of. So I bolded and I underlined and clinicians, because when it comes to somebody's pain journey, we're the leader. We lead the pack on this deal. And so if we don't understand chronic pain and updated thinking around chronic pain, well, we could lead them the wrong way. On the other hand, if we do have a current understanding of what's going on with the pain research, then we can make a big, big difference in their life. And the clinicians are the ones that are going to lead that. So no, it's no longer biomedical. It's biopsychosocial. That is the way. And if you're a Star Wars nerd like me, you get every bit of this meme. So what does biopsychosocial mean exactly? Well, first of all, it means purely bio is dead. And if we are still working on a purely biomedical definition or construct, then we're probably missing 2/3 of the full equation. That's a big deal, right? Focus of pain treatment was once on the bio aspect. And what does that mean exactly? Well, that means we're looking at an MRI and we see a disc bulge. Well, let's say we're a surgeon. If we just go in, we'd take that herniation out. That'll be fine. Or if we shoot this up with cortisone, that's going to fix it. The inflammation's gone, taken care of, not a problem. Well, it's not like that anymore, especially if you consider low back pain. Think about all the advancements in the medical profession, the advancements in surgery and techniques and all of that. But focusing purely on bio in the medical profession has led to low back pain. It's now the leading cause of disability globally. So it hadn't worked out very good, just looking at things from a purely biomedical construct. So what does biopsychosocial mean? Well, let's break it down a little bit. The bio, that's genetics, physiology, neurochemistry, and tissue health. The psycho part is perceived control or lack of, catastrophic thinking. I'm 40 years old and I already feel like this. What am I going to feel like when I'm 65? I'm going to be a mess. Depression, anxiety, anger. That's all the psycho part of it. And then there's the social aspect of it, the socioeconomic status. Can they afford care, right? Skepticism. What is their level of faith in their providers? Then there's family circumstances. There's social learning at school. There's social support. Is there any family support around their pain experience or their search for a treatment and a cure for it? So let's talk a little bit about yellow flags. We know red flags, right? Somebody who was hurt in a traumatic event, they need to get x-rays. That's a red flag, right? But what about yellow flags? That's where we really take into account the psychosocial factors. So I think they're always kind of a little bit boring, but they really, really are important. Annie O'Connor has a great book called World of Hurt that I highly recommend, and she's an excellent speaker if you ever get a chance to go see her. But yellow flags include things like negative attitudes, that back pain is harmful or potentially severely disabling. I had a patient one time that another provider, not a chiropractor, by the way, another provider told her that her back was like a dried twig. And if she moved too much, it was just going to snap, which we know is absolute hot garbage. But that's a yellow flag. They believe that their back's about to break. Right? Fear avoidance behavior and reduced activity levels. Fear avoidance meaning you're avoiding activities that you love, that feed your soul and all of that good stuff because you're afraid it's going to hurt. Well, that leads to deconditioning after just 7 days. Takes longer to recondition. So that's kind of a stair step down over time, right? Fear avoidance is big. An expectation that passive rather than active treatment is going to be beneficial. A tendency for depression, low morale, social withdrawal, social or financial issues, negative beliefs about their future, their ability to recover. A lot of that comes from what clinicians have told them in the past. So it's important to find these things out. And words matter. Beliefs matter a lot when it comes to chronic pain and getting out of it. Overall, you can just look at it as stinking thinking, all right? And we got to figure out how we're going to turn that 180 degrees and go the other direction with it. Yellow flags can delay recovery. Patients who report maladaptive socio or psychosocial factors have a significant increase in the risk of poor outcome. They don't get out of pain as good as folks who don't have maladaptive psychosocial factors. And two of the most frequent yellow flags you're going to run into are fear avoidance, which we just talked about, avoiding activities you think are going to be harmful, but probably aren't. And then kinesiophobia, fear of movement. So let's define chronic pain real quick. The United States National Pain Strategy defines chronic pain as pain that is experienced at least every other day for a period of 6 months or more. And then we have John Hopkins, who says chronic pain is pain that has lasted for more than 3 months. So I usually use the pain that's lasted over 3 months is usually kind of my benchmark. But here's a very interesting factoid, if you didn't already know this. Excuse me. Johns Hopkins says, health economists wrote in the Journal of Pain, the annual cost of chronic pain is as high as $635 billion a year, which is insane. And it's more than the yearly costs for cancer, heart disease, and diabetes all combined. So here's a question for you. Now, we know that lots of times pain is not appropriate, but we also know that tissue has a healing time. If you break your bone, you get it casted. Well, I mean, that's 6 to 8 weeks. It's healed up, right? Muscle tears, 4 to 6 weeks, roughly, depending on the severity. So why does pain continue beyond the time when tissue healing is finished? We're going to talk a little more about that, right? I'm not going to answer it right now, but we're going to get there. They're also looking at chronic pain as being kind of a tent or an umbrella with lots of little things underneath it. So what other conditions may come from or stem off or be under the umbrella of chronic pain? Well, they're looking at fibromyalgia, chronic fatigue syndrome. A lot of these make a lot of sense, but TMJ as maybe being part of a chronic pain syndrome, low back pain, of course, irritable bowel syndrome, migraines, and then maybe even more larger global things like autoimmune conditions, MS, rheumatoid, lupus, things like that. So obviously, chronic pain is a big deal. And then the terrible triad. How many patients do you know that could fit into this? Pain may cause you to become preoccupied with the pain. A lot of people really enjoy their pain, don't they? They want to talk about their pain. They want everybody to join them in their pain. But so patients may become preoccupied with it. Depressed and irritable. Depression and irritability often lead to sleep issues, being fatigued all the time, weariness, leading to more irritability, more depression, more pain. And this is called the terrible triad of suffering, sleeplessness, and sadness. So, as I mentioned, my mentor, Dr. James Lehman with the University of Bridgeport and the orthopedic diplomat, now called the neuromusculoskeletal medicine diplomat. And he says it all starts with the diagnosis. And I agree. Chronic pain is not diagnosed enough. If ever, I didn't used to diagnose chronic pain. I do now. So we have chronic pain due to trauma, G89.21, and we have chronic pain syndrome, G89.4. That might be a couple of codes you might want to write down and keep track of. So just a real quick basic pain refresher. Nociception is information coming in, and the brain makes the decisions on how important those signals are. And then what are we going to do with it? Is it going to hurt? We're going to suppress that. It doesn't matter. Or are we going to let it up to the higher centers, right? And then you got the pain neural matrix, which stores pain in the limbic system. This is important. It recalls pain experiences. It remembers previous injuries and threats. It also remembers things that doctors have told them in the past, right? Take those yellow flags, throw those in there. It factors them all into future decision-making with regard to safety and the pain experience, and it will modulate your pain appropriately. So it takes into account your beliefs about yourself, and we've talked about that, your current health, your current abilities, and your beliefs and fears about your future abilities and pain. It takes into account what providers tell us, good and bad, optimistic and limiting, hope-inducing and fear-inducing. And these create your yellow flags that we've talked about. So the neuromatrix tries to combine all of this information into its own brew here, and it can absolutely alter its tissue sensitivity to best match the perceived danger level, whether real or not. Without the brain, there's no pain, and the brain can do all of this. I tell patients, what you feel runs through a filter first, and then you feel it, and that filter has the ability to amplify the signals inappropriately, keep them neutral and appropriate, or if we learn to, even dampen the signals. So chronic pain findings and the muddy map. People with chronic lower back pain demonstrate changes in the brain on many levels. Research has shown that even the brain volume can decrease in chronic pain patients. So this is a little representation of the map getting muddy here. It's just not clear. There is a map in our brain of every single joint, how it moves, the extent of its movement, what kind of load it can be under as it's moving or at rest, and of every joint in our body. And so chronic pain people, that map gets a little bit muddy and less clear. So the adjustment is thought to be more of a local mechanical force, but the result can be a larger global neurological effect. So how does the central nervous system turn mechanical inputs into a sensory experience? These are good questions to contemplate. And what is unique about an adjustment that everyday movement doesn't possess or provide? The brain welcomes sensory inputs from joints to know what's happening and to construct the best responses. So let's talk a little bit about our sensory motor system. So sensory motor drives motor output and quality, smooth, non-aberrant movement. It depends on a continuous flow of clear, accurate sensory information coming into the brain and turning it into involuntary motor, like our postural and our movement. So let's go. Sensory inputs that contribute to spinal stability are going to connect directly onto motor areas of the brainstem. Sensory inputs that contribute to spinal stability, I just mentioned postural muscles, right, are going to connect directly on to motor areas of the brainstem. So we get sensory through three main areas: our eyes, our vestibular organ, and the deep upper cervical muscles. And you can test those through Romberg's, the sway. A marching test, you have somebody close their eyes, do high knee marches, about 40 steps, and with their eyes closed, if they turn 45 degrees either way, or they might have chronic pain or some sort of sensory motor malfunction. And then visual pursuit is another good way to test what's going on. So this is super interesting. I learned this in the neuromusculoskeletal medicine course. So muscle spindles. When we say we got a lot of sensory info coming in from the deep upper cervicals, it is absolutely fascinating. So think about the first lumbrical in the hand has 16 muscle spindles per gram of muscle. So think about how sensitive your hands are. I play the guitar, so I don't even have to look at my hand. I know exactly where it's going. I feel everything going on with the strings. I'm super highly tactile, sensitive, right? That's 16 muscle spindles per gram. In contrast, the obliquus capitis inferior has 242 muscle spindles per gram. That's just absolute insanity when you really kind of boil it down and think about it. So it's reasonable to expect that the adjustment to the spine, particularly the C-spine, you would expect that to stimulate the sensory motor framework and influence the descending control of posture and stability in a global way. Now this last sentence here, it says that this is effective for any joint, right? But it also depends on, how much sensory information is in that joint, right? So I think the upper cervical guys, they got something going on, right? So sensory motor is the way we perceive our body through sensory input and determines how we move it, and adjustments seem to improve the way the body is perceived and helps clear up these muddy maps that we were talking about. So peripheral versus central. Okay, so a peripheral source is, hey, my knee hurts. My ankle hurts. A central source of pain is more central nervous system related, pain that is inappropriate. So to keep from getting too confused, you can have peripheral pain versus central nervous pain, but you also have peripheral sensitization in your peripheral nerves. I know that can get a little bit confusing, but you can have this peripheral sensitization occurring at the site of injury as well as in the central nervous system. So the nociceptive signal was already enough, but due to the sensitization, it hurts worse. Some of this could be metabolic. So targeting metabolic factors, for instance, using low carb or keto diets, they say this research suggests there's maybe promising new avenues for diminishing the hyperexcitability or the sensitization. The words got a little messed up in translation here, but there's a program called Practice Mechanics and Quadrant Analysis by Dr. Rob Pape, who is he's a genius. But he says indicators that point towards an abdominal or inflammatory issue could be multiple areas of pain, generalized tenderness to palpation, and abdominal tenderness to palpation. So something else you can think about. So one good way where you can talk about with your patients or think about or relate to them, why would tissue heal but continue on? And so we talk, it's more of a centralized pain now, right? You can have pain at a peripheral source, but the longer it's allowed to exist, the more of it also migrates to a central source or origin. And so the way to explain that is say, have you ever heard of phantom limb pain? Most people have. Every now and then you run into some that don't, but most people know what phantom limb pain is. And phantom limb pain is basically a pain memory. How can something hurt that doesn't even exist anymore? It's burned up in an oven somewhere. So how does it still hurt? And then that will kind of get their wheels turning a little bit. So central sensitization, you say that 3 times, I dare you. The feelings in phantom limb pain are real. They're real. It is a pain memory. It can itch, it can tingle, it can hurt. It can even worsen if somebody is coming closer to it. It'll worsen. It doesn't even exist. It is a pain memory. So functional impairments in cervical spine associated with chronic pain. So pain out of proportion for the peripheral findings. Decreased cervical muscle strength, decreased flexor muscle strength, lower movement velocity, jerky movement patterns, irregular and stiffer movement patterns, increased postural sway. Remember when we get our sensory motor? If we are still and we take 2 of the 3 out of the equation, so we take the eyes out, we're not moving, so the vestibular organ doesn't matter. So we're dependent purely on upper cervical sensory information to keep us balanced. And so if you take 2 of the 3 out by closing your eyes and standing still, and people are doing this, then there's something going on, right? That's Romberg's. Functional balance disturbances and dizziness. You can get that through the marching. And then the breakdown in movement, in eye movement control, which you can test through visual pursuit. So I got to admit, this is probably the ugliest cover to a book that I have ever experienced really in my entire life. I don't know what they were thinking, but they're Australian. So maybe that has something to do with it, because Australians are crazy in a good way, in a good way. But this book is called Explain Pain by Mosley and Butler. Highly, highly cannot recommend it enough. So we're going to talk about some of the things they say, but this is a very, very key concept. It'll take us 2 or 3 slides to get there. But we believe that even if problems do exist in joints, muscles, ligaments, nerves, immune system, or anywhere else, it won't hurt if your brain thinks that you're not in danger, because our brain uses pain as a protection mechanism. If it doesn't think you're in danger, it's probably not going to hurt. In exactly the same way, even if no problem whatsoever exists, your tissue is healed. If no other problems whatsoever exist in your body tissues, nerves, or immune system, it will still hurt if your brain thinks that you are in danger. They say it's as simple and as difficult as that. That's pretty cool. Factors leading to or deepening chronic pain. Things that providers say to people. I hear it from surgeons, patients who have been to surgeons. I hear it from physical therapists. I hear it from massage therapists. Patients, what these people have told the patients who are sitting in front of me. I've heard it from primary care physicians, nurse pracs, and I've heard it from a ton of chiropractors that don't understand what their words do to people. You have the back of an 80-year-old, but it's somebody who's 40. Is that useful? Is that helpful for them? That might scare them into more treatment, but it's not helpful for them getting out of pain and dealing with their condition. It's not a question. I've heard this one from surgeons. It's not a question of if you'll have surgery. It's a question of when. Who knows that? Who broke out their crystal ball and said that? It's unbelievable that people, convince people that you're going to have surgery. Well, what is that person going to do? Fear avoidance. They're going to start slipping back. They're going to start degenerating. So it's just not right. I'm really, really concerned about your future. If we don't put everything we have into correcting your lost curvature, that's not helpful for them. It's not helpful. Okay. Explain pain. Hypnosis. They bring up this as an example. Hypnosis is fascinating. So many have had major surgery while under hypnosis without anesthesia. I know you've heard of this because I've seen it on TV myself. So if it were if pain were purely tissue damage that was causing pain, well, wouldn't the alarm bells go off and they'd start screaming and having a fit because they didn't have any anesthesia? Nope. They say the whole point is that pain depends on many different factors, and it's the brain that decides whether something is going to hurt or if it is not going to hurt. All the time, every time, 100% of the time, with zero exceptions. Now, this is a cool way. You can screenshot this or whatever you need to do. Email me. I'll send it to you. But this is an excellent way to explain things to your patients. So this is the pain experience. And so the A here, the circle that represents A, is somebody's full and average and normal ability level. They can perform and do just about anything they want pain-free. And so you'll see the little dotted lines. It says the point that you feel pain. So if you'll notice, you start to feel pain just as you're approaching the line where if you were to reach that line, you'd probably cause tissue damage. Okay. And so you feel pain just short of that. So you back up a little bit. You don't cause any tissue damage. You did what you needed to do. Everybody's happy, right? You'll see that the little arc goes over the tissue damage line because there are certain times where you have supernatural ability, like somebody picking a car up off of an injured kid or something. They're probably doing tissue damage, but they got it done and saved some lives. So that's what that's there for. So let's take the B person. What has happened through chronic pain, the tissue damage line didn't change at all, but through central upregulation, sensitization of the central nervous system and the pain neuromatrix using pain as a protection mechanism, Yellow flags, all of that stuff combined has moved that tissue sensitivity line down lower to where a person is more and more limited in what they can do and how they can do it and to what extent they can do it. So they're nowhere near tissue damage, but they're hurting all the time with fewer and fewer activities. So the point is, let's get that line bumped back up. So use of imaging. Radiological findings can be a turning point for patients depending on how the clinician chooses to frame the findings and how they word it and communicate those findings with the patient. Choosing wisely came along on purpose because we were doing a lot of either unnecessary x-rays following up, whatever, but we're also sometimes the increased x-rays were leading to unnecessary treatment. So that was part of why it came about. So how do we communicate imaging to the patient? It is super vital to whether they're going to be successful or whether they're not going to be successful. So this is an incredible graphic from Spine Care Partners that was shared online. Go to Spine Care Partners and get your own copy and really support these folks because it's incredible. But I show that I have this sitting right at my exam desk. And when x-ray report comes through or they give me one they got from another provider or whatever, just like the other day, I had a patient say, oh, yeah, my C5 is just sandwiched. It's like it's almost non-existent. I mean, this dude's 35. So another chiropractor had convinced them that they're screwed for the rest of their life because they have a thinning at C5, C6. I said, what did they happen to tell you that C5, C6 is probably the most common area to get a little bit degenerated because that's where the curve starts to go into the thorax and it carries the majority of the weight of the head. And if you'll look at this sheet, 30 to 40-year-olds, if you go down to disc height loss, at least 34% of people in your age group have that. 40% have a bulge, which can kind of mimic height loss. And did they tell you that there's a really good chance that that's just part of the process and probably not even your pain generator, and that you can do anything you want to do and you're probably going to be just fine? Did they tell you that? No, I thought I was messed up forever. Like, well, exactly. So at least 30% of people with zero low back pain have disc bulging into their spinal canals, sometimes markedly, yet they have zero pain. Imaging findings of degeneration, they're in a high proportion of asymptomatic individuals. Many imaging-based degenerative features are likely part of a normal aging and unassociated with pain. So we make a big deal out of some degeneration or some disc height loss and stuff like that. And it's just not usually that important. And if we're using words correctly, we can either push them off of the cliff into chronic pain or deepen their chronic pain, or we can use our words to start beginning to help them climb out of the chronic pain pit. We really do have that much power. So what is treating from an image? Well, current thinking and current guidelines, they caution us against treating from an image, right? You can't just look at there and go, oh, there's a disc. They'll go cut that out and they'll be fine. Oh, it's degeneration right here. That's it. That's all it is. You can't cut out pain. They figured that out. You got to treat the clinical patient sitting right in front of you. If you can correlate the image with the clinical findings, well, then you may be on to something, but you can't just treat from an image. 60% of asymptomatic 40 to 50-year-olds have degenerative findings on X-ray and MRI. It's normal. And that number just increases as we age, right? So communicate with the right words, because if we're just treating from an image and that's it, people are getting surgery, they're getting epidural spinal injections, and they're getting medications that they just don't necessarily need. So pain as an output behavior. It's been shown that pain, like low back pain, varies throughout our lives, comes and goes. Over 60s, actually, there's less back pain than the under 60s. Bet you didn't know that. Yet they have significantly more prevalence of degeneration. And once again, pain is not necessarily related to the amount of degeneration or tissue damage. So this is kind of how I go about it. This section is a little bit scattered because there were so many things I wanted to tell you about, but kind of some of the things that I share with my patients when I'm trying to educate them on chronic pain. But the first step to doing something about it is understanding it. So it's got to be a face-to-face talk. For some of the things that I've got in my office, like let's say maybe decompression or something, I've got a video for it, or low-level laser. I've got a video for it. I get tired of saying the same stuff all the time, over and over and over. But this talk needs to be face-to-face because they got to understand it to address it. So communicating and educating chronic pain is difficult, and it's full of landmines because they can easily misunderstand what you're trying to tell them. It's always good to lead off with the phantom limb pain talk. And people can do, I tell them, you can do passive therapies. You can go to a chiropractor and get adjusted. Every week you can go to the PT and you can get that. You can take all these medications and you can and still not get better if you're not addressing the centralized, upregulated aspect of it. The central nervous system remembers your previous injuries. It imprints it on our limbic system, like I mentioned before, and then it uses that permanent. Those pathways are permanent, right? It uses that information to make future decisions about inputs and information, and it tries to predict the future of what it thinks is likely to happen. The expectation of something being painful changes the way a patient feels and moves. This stuff is fascinating. I tell patients, because you never know what their perception of chiropractic is. I say, I'm not teaching you chiropractic stuff. This is research pain science that is current within the last 10 years. At its core, pain is a system of protection. It's fluid and the boundaries are arbitrary at best. That's kind of the definition of neuroplasticity. And the gate theory, they showed us in 1965 that the nervous system can absolutely modulate pain up or down. So what arrives is the input after it's been interpreted and modulated by the CNS. Remember that talk about having a filter and then you feel it. That's exactly what I was referring to. So neuroplasticity is absolutely fascinating to me. It refers to changes in neuronal properties, structure, and organization. It's how the nervous system encodes new experiences. And the CNS can be reprogrammed to unlearn bad habits, but it can also be programmed to relearn good habits. And I first became aware of neuroplasticity when my dad had a few strokes, lost the entire left side of his body, basically, the use of it. And so I went through this book right here, and I think if you're kind of nerdy like me, you may enjoy it, but it's fascinating stuff. Neuroplasticity, so it refers to changes within different areas of the spinal cord and brain and may help to explain the transition from acute to chronic conditions. Right? Why does pain persist beyond tissue healing? And neuroplasticity may be a big reason. That's why some individuals continue to experience pain, just like we just said. Here is a book that I recommend every chronic pain patient have. Most will not read it because people don't like to read. But this book is absolutely wonderful. David Hanscom is an orthopedic spinal surgeon. I tell my patients that he talks about his personal experience with pain, his journey. He talks about this new updated, upregulated, sensitized central nervous system, all of this new research. And then in about chapter 10, he gives some great techniques for just getting everything to chill out a little bit. And that's really more the cognitive behavioral therapy, the mindfulness that the American College of Physicians recommends in chronic pain. In fact, if you don't know this, the American College of Physicians, it's Kazim et al. It came out in 2016, 2017, I believe, in the Annals of Internal Medicine. And the American College of Physicians updated their recommendations for back pain treatment. And for chronic pain, they recommend your first line therapies be spinal manipulative therapy. That's what chiropractors do. And that's the medical boys. That's the largest medical organization in the world says spinal manipulative therapy can be an effective first line treatment for back pain, chronic back pain. They also say acupuncture, massage, exercise, low-level laser, and then more mindfulness stuff like yoga, Tai Chi, mindfulness, cognitive behavioral therapy. So if you didn't know what I was referring to, it was Casimedo. And then when a chronic pain sufferer with upregulation undergoes, this is in the book that I just shared, Back in Control. When a chronic pain sufferer with an upregulated system has surgery, everything goes perfectly. Like it is a picture perfect surgery, the patient will still experience chronic pain at the new site of surgery, the new site of insult or injury, in 60% of the cases. It's just incredible. That's a 60% failure rate for what should be a successful surgery. I don't like those odds at all. I don't know about you. A functional MRI research project demonstrated that an upregulated central nervous system can amplify, remember the filter, amplify pain stimulus by up to 500% after being in pain for only 3 months or more. That's incredible and significant, when you agree. There was a case study of a World War II vet having routine chest x-rays revealed a bullet he's been carrying around in his neck for 60 years and had no idea. You can talk about people who've had shark bites and didn't have any pain. I mean, there's lots of examples. In experiments, this is interesting and kind of funny. In experiments, males have higher pain thresholds when examined by females, right? Because we're being tough, right? Because we're being examined by a female, we got to be tough. But when they're accompanied by an attentive and caring spouse, they demonstrate more pain than when there's an uncaring spouse with them. Yeah, guys, come on, get it together, guys. So it hurts because the brain has concluded for some reason or another you are threatened or in danger and you need protecting. So you hurt more. A systematic review of 33 studies demonstrated the presence of asymptomatic degeneration, and it increased from 37% of 20-year-old individuals to 96% of 80-year-old individuals. Asymptomatic. 96% of 80-year-olds are walking through the world with tons of degeneration, but they're asymptomatic. This is, I found interesting. Cussing. Dr. Richard Stevens, senior lecturer in psychology at Kiel University, in tests, people who swore when their hand was put in a bucket of ice cold water withstood the agony for 40 seconds longer. So if you are prone to profanity, you probably don't hurt quite as bad, which is why I feel pretty good most of the time. So broad management protocol. Not only does the American College of Physicians say that, everybody says that. Everybody agrees with them. It can't just be getting your back adjusted. It can't just be acupuncture or just exercise or just mindfulness. It's everything combined, working towards one goal, right? Correct intentions and communications from the provider, using our words correctly and responsibly, giving them a diagnosis. That's a big deal. They did research where they just gave them a diagnosis, and that made a huge difference. Increase activity and rehab responsibly. If patients wait to move until it quits hurting, they're going to be in trouble. They got to get moving. Think about when somebody has surgery. They've got a joint replaced, a hip or a knee completely replaced, yet they've still got them up walking around the hallways 6 to 12 hours after surgery. Right? Movement is healing. That's why chiropractic is so effective. It's because movement is healing. So in honesty, overdoing it in the beginning can do harm, but find a baseline and hammer it. Then you add 10%. If they want to go golfing, but they haven't gone in 2 years, tell them to go hit some balls at the driving range. See how that goes. Went well? Okay. Go play 1 or 2 holes. Try that. Went well? Add 10%, right? But hurt does not equal harm. Lots of times when people are in injury, they want to sit back, they want to protect it, and what they need to be doing is using it. Hurt does not equal harm. So yeah, chronic pain treatment recommendations. We already talked about spinal manipulative therapy, right? More sleep. Sleep's a big deal. 8 hours is like, that's the baseline. Active meditation. You'll see these, the description of this in that Back and Control book by Dr. Hanscom, but active meditation is great. Creative writing. Yeah, I didn't know either. Stress and anxiety reduction, cognitive behavioral therapy, acupuncture, Tai Chi, and yoga. It would be helpful to reframe, remap, and relearn, right? Reframe means reframe unhelpful perspectives. You got to retrain. Sometimes when they've come in and they're convinced that they're screwed for life, you have to turn that around. And sometimes that means you have to disagree with other providers, which doesn't always make you super popular, but we're here to get the patient better, right? That's my goal. So you have to reframe unhelpful perspectives, interpretations, and beliefs. Degenerated becomes deconditioned, for example, right? Imaging findings are age appropriate. That's normal. It's average. You're supposed to look like that. And it's not a matter of when they're going to have surgery. And then remap things. Spinal manipulative therapy and movement-related activities can help with proprioception inputs, right? Help clear the muddy maps. We've talked about this. Smoother muscle movements. And then relearn. Stimulate the motor learning, whereby the brain learns to understand and use the body and the joints to a healthier degree. Movement, functionality, strengthening, stabilizing, and activity. Keep moving. Remember that pain sensitivity threshold. Keep moving it higher and higher. So what do patients really want? They did a research research project not very long ago. We look at February 2022 here in Spine Journal. A sum of 419 patients with back pain upon initial presentation to to a spine clinic. I lost my place. And 198 physicians. So 419 patients, 198 physicians, all volunteered to complete a survey. What they really wanted was an explanation of what is causing the problem. They want an improvement in their level of pain, and they want an improvement in the ability to perform daily tasks. That's all that mattered to them. What they really did not want, they didn't want surgery. They didn't want medication. Patients didn't place as much importance on diagnostic testing, medications, and surgery like physicians assumed that they would. Physicians understand that the back pain patients want improvement in both pain and function, but they underestimated the importance of an explanation for the pain. Remember, I told you just a diagnosis makes a big difference. So we're getting to the end of this. I wanted to show you, this is the book of mine you can find on Amazon, The Remarkable Truth About Chiropractic, A Unique Journey into the Research. And this is the podcast, Chiropractic Forward. I hope you'll join me on there. In conclusion, chronic pain is frustrating for everybody, provider and patient, everybody, because it's tough. Somebody's been in pain for 20 years. It's hard to turn things around. The pathways laid down are permanent, like we discussed. That means there's always going to be work to do to stay ahead of it, right? When providers know and understand chronic pain and this updated research and way of thinking, then we've got a bigger toolbox we can help these people with. And when you have a really good teammate in your patient, then and it's consistent and they're driven to recover, then we're on a good path. All right. I think that's it.
That was fantastic. And let me just say that I don't know that I've ever given much thought to how much mentally plays into pain. This is probably one of the funny, you tell great stories.
Oh.
I also have a high pain threshold due to that. Person. I was definitely say learn another life, but this was a fascinating presentation. Thank you so much.
Absolutely. As you can tell, I'm pretty passionate about it. We really are in a very powerful position to help these people.
We absolutely are. And I just want to say that Dr. Williams has put his email address on here. So if you have questions because you are watching the webinar recording this week and have questions that you would like to see answered, you can email him directly. You can email me and I will forward those over to him. Either way, thank you so much, Dr. Williams. And everybody, I'll see you at the same time, same place in 2 weeks. Bye, y'all.